Okay, so hopefully it is recording.
It looks like it. It looks like it is. It says it's being recorded, Harold. So thank
Okay, good. Good. Okay, so let me introduce you, Christina. Welcome, everyone, to the workshop. Well, not the workshop, but our seminar this month. And I'm so thrilled. We are so honored to have Christina Puchalski give a talk on something that she has studied virtually her entire lifetime. So let me just say a few formal words about Christina. Dr. Puchalski is an international leader in the movement to integrate spiritual health into clinical settings, education, and policy. She is professor of medicine and founder and executive director of the George Washington University's Institute for Spirituality and Health, GWish, at George Washington University in Washington, D.C. Dr. Puchalski's work has influenced clinical practice globally through clinical guidelines and research. She has received numerous awards, being named in 2018 as one of the 30 visionaries in the field of American Academy of Hospice and Palliative Medicine, and in 2022 received the Debra Sivesind Career Award for outstanding contributions to palliative care. So we are so excited, Christina, to hear you speak. So go ahead and take over.
you. Thank you, Harold. And I just want everyone to know that Harold and I met many years ago. You were one of my first mentors when I worked with Dave Larson. And I started an elective in spirituality and health as a medical student. And I did some research and found out about your research and also Dave Larson's research, and Dave became part of that elective, and the rest is history. So I just want to thank you for that, Harold, and for your great work and contributions to this field.
Thank you, Christina.
So Harold asked me, what I wanted to talk about, and I really, especially during the pandemic, but now as well. I don't know how many physicians are in the room or nurses. I'm going to guess there's a mixture, but clearly there's so many struggles in healthcare these days as healthcare becomes more of a corporate model, but also people are tired and higher level of burnout, high level of attrition of nurses from health settings. And patients are obviously feeling a lot of that discomfort. I want to just share a brief story of a patient I saw recently who's relatively new to my practice, but she was reflecting on how the prior physician, not in our setting, was so stressed. And even there was this pressure in the hallway, she said, of nurses saying, Dr. So and so, you're behind, and how this physician, and I'm sure it hurt her very much, took the coat down from the hook and put her hand behind the patient and says, okay, we're done. And, that is hard for people. And it was hard. I'm sure it was hard for that doctor. I don't know her, but I know we are all under tremendous stress. And yet, what I've experienced in my own practice and many people have talked about is the critical need for the sacred in clinical care. How do we integrate spirituality? It's more than asking about doing a spiritual history. And I hope I can share a little bit with you about that today. So the Surgeon General declared loneliness as an epidemic and talked about the widespread loneliness in this country, especially post-pandemic. I did have the privilege to talk with his staffers who reached out to us. And loneliness is actually one of the spiritual distress diagnoses that we developed in a consensus conference. So their spiritual distress is a health problem, and very important that we address that in clinical care. But how do we address that? So we know, I just mentioned this about the burnout and prevalence of suicide. While thankfully it's getting better, but among physicians, very, very, very high. Sadly, in our own organization, a resident took his life. So these are real things that have been happening in healthcare, and we're in a very, very challenging time. I think, Harold, if you and I were probably to talk about this, we would say, well, back then when we first met, there was a challenging time. There's always, right? I mean, there's always a challenging time. There's always changes. But I think the root of all of this work is spiritual. And if we can keep that in mind, about how it's not just what we ask and say, it's how we bring our presence into our encounter with patients. So corporatization of healthcare, doctors and patients alike, the downward spiral, we're in this spiral right now, and burnout is high suicide rate. And then interestingly and sadly, there has been a sharp decline in medical school applicants. So why is this happening? What is going on? And while I'm talking about physicians here, what about the patients? I'm sure many of you, whether you're clinicians or even in a role as a patient, it's harder to get appointments. I have patients saying, you made a referral to the neurologist. I can't see him for 8 months. So there's so many struggles that's not making healthcare peaceful. But we can do that in the exam room by recognizing the sacred. So reintegrating spirituality into health, that sense of hope, healing, and transcendence, and recognizing, when I had many opportunities. I did research at NIH before I went to medical school. I could have been a researcher, but as I was isolating proteins on a column and watching all the postdocs getting excited about that, I thought, this is not my call. And my call is to serve others, particularly patients. And that's a very deep call that all of my colleagues who are clinicians share. So how do we create systems where we can bring back that attention to our call? And we have a program that we developed many years ago called Reflection Rounds. And I'll talk a little bit more about that. When I went to Rwanda in 2019 to do a mini ISPEC course, I'm going to talk about that course. And I had a chance to visit this incredible museum, looking back at what happened in Rwanda, where family members killed other family members. They were different tribes. And how the younger people who were there talked about healing in community, that's what is bringing and has brought that country back together. It's a work in progress, obviously, but we need that as well. I think back to returning to clinic. We started with Zoom, and it was July of 2020 when I returned to clinic. We were all afraid. We were triple masked, and it was hard. It was really hard to return. And we continue in our own organization to have the healing, sort of looking at how we as clinicians can heal. And a lot of that needs to be done in community, not in isolation. So I want to switch to a model of whole person care that was first described in 1964. Paul Tournier developed this work. He was in France. I believe as a child, he was in World War II or towards the end of World War II. And so he experienced that broken world. So aren't we in a broken world right now? If you look back at history, after every global pandemic, there's tremendous social unrest all over the world. So, I notice the lack of kindness, the social media, and I'm not talking even about politics, about anything. There's a lack of politeness, a lack of caring for the other. So I think, every time I look at this slide, I think, yes, Paul Tournier experienced that. It wasn't a pandemic, though there was a pandemic at the beginning of last century that resulted in a Second World War. So looking at what we need to do to bring healing to our world, not just our healthcare system. So he developed this model of the whole person care. He was an internist and then became a psychiatrist. So a little similar to Harold's path. But he described that and started medicine and ministry groups, which were physicians and clergy meeting together. That came to the United States in the 50s and 60s. And so there was a medicine and ministry group. There was one in California that ended up being more New Age. And then there was one here in South Carolina where I spoke once, and then I did their quote unquote end of life, where they decided to close it was 50 years and they decided to close that. Great group that taught, and in the United States, not only was it physicians and clergy, it became nurses, chaplains, and others. It was a fantastic group, and I was privileged to be a little bit part of that. Cecily Saunders for Palliative Care described total pain again in the whole person model. And then when I went to med school, though I didn't go to medical school then, but what we talked about was the biopsychosocial model. And that has been what's been used a lot. And barely do we cover social, but spiritual got dropped out of that. So in my work with Dr. Betty Farrell and others, we looked within palliative care, spiritual distress was a required thing for us to address, but there was nothing about that other than everybody should get a spiritual screening. And so our conference in 2009 brought together interdisciplinary leaders, including chaplains, including clergy from different denominations to develop guidelines. And this is where, we recognize that whole person care, and that spiritual care, the dimension of spiritual care was a critical piece of that meeting. Then in 2013, I worked with colleagues to look at this on a global level. So this gave us some definitions and guidelines with the US. Here we broadened it. We went to Geneva and broadened it with a global audience, and built on a definition that we did in 2009 and then in 2013. I will talk about that definition in a minute. I want to highlight Tracy Balboni's work. Tracy is a very good colleague and friend of mine, and I was part of this. Harold, I think you were too. Were you? I think you were part of this meeting. Yeah. And so there were two big pieces. One was, and by the way, the lead author, this is an interesting story about this field. The lead author, Howard Koh, is a good colleague of mine. He is at Harvard. And at that time, the editor of JAMA was his student. And yet it took 4 years for that paper to get published. And Harold is shaking his head because spirituality and religion still raise issues with people. And it's fascinating to me. I'm going to go up a little bit on this, Harold, because I love this area of quantum theology. And there's a quantum theologist from Ireland that has looked, and I can't describe it fully to his level, but saying that, in the Bible, when the wind blew over the earth, that was the spirit, right? And over human beings weren't even there, we hadn't even evolved yet. But in the evolution of human beings, there were many expressions of understanding the spirit. Native cultures, it was the land. And then eventually, we had many gods, and then one God, and then a triune God. But as what he says is we start with the spirit, and then different religions are or cultures are expressions of how they understand that. And I so like that. But nonetheless, spirituality and religion still have a little bit of resistance in our culture, getting better. So the first multidisciplinary panel was, how do we integrate, and they assessed really strong evidence, not simply association studies, but evidence that met the Cochrane criteria. So out of thousands of articles, we ended up with only a couple hundred who met that criteria. So there was enough evidence to say that we could incorporate spiritual education into the care of patients with serious illness. So what I say is, while I am a palliative care practitioner, I'm also an internist and I do geriatrics. So serious illness can happen at any age and people can recover from it. So it's not simply end of life, but people do deal with serious issues. It may not be even illness in their lives. Incorporate it into the training of interdisciplinary teams and incorporate specialty practitioners, which would include board certified chaplains as well. And then more recently, the paper is at the bottom long. And in that study, they did look at evidence and they recognized spirituality as a social factor associated with health. And then more recently, I was part of a paper that came out of K. Long. Dr. Long was the lead author, but Vanderweel, which many of you probably know, his research does a lot of research on spirituality and religion as a social determinant of health. And the paper actually shows that there's evidence for that. So 3 very solid studies there. Building on all our work, we started an initiative funded by Templeton, a 10-year vision of advancing spiritual care and looking specifically at interprofessional spiritual care. So in those guidelines, what was defined was the generalist specialist role of spiritual care. So all clinicians should be doing this at a generalist level and not just asking, but a little bit more about patient spirituality, recognizing that board certified chaplains within healthcare settings are the specialists. And now my colleagues at Interfaith America are looking again at how can community clergy be involved in that too for people that are associated with a faith-based community. That got changed when HIPAA came into being about confidentiality, and many people noticed that clergy visiting patients decreased, and I think it was partly in that, so it's good to see that. So I have been passionate since I was looking at an article that was written in 2001 when GWish was founded, the institute that I founded. And basically, I talked about this, and now we're trying to bring this into fruition, which is that spiritual health is a fundamental part of whole person care, as spirituality broadly defined, which I will go into that. And that all of us as clinicians should assess, diagnose, and treat distress. So it's not just that I say, oh, I do a FICA tool, you're spiritual, fine, I have a chaplain on the team. I need to be part of that conversation as well within my limits scope as a generalist. I'm not a chaplain. I'm not trained in that way. So being very careful about those boundaries, and that hoping that this becomes a standard of care across clinical settings. We're working with people in other countries too who are trying to do this in different global settings. There are 3 aims to that initiative. One is building an infrastructure. And so we have a lot of partners that we're working with. Increase clinician knowledge. I'm going to focus a lot on that, which is our ISPEC course. And then we're piloting demonstration projects, which are like QI projects in that generalist specialist model. And it's amazing what has happened with those pilots. It's such an honor to work with them. And by the way, Betty Farrell and I stole this model from how palliative care became a field. Because back in the 90s, when I actually did work with late 90s with Joan Tino and Joanne Lynn, who are leaders in that area, how palliative care grew was doing demonstration projects in how to address pain. Pain management was not required back then, and also goals of care discussions, as well as other things. And then they did Betty did LNEC, which is training nurses in end-of-life care, and then EPIC was training physicians. So really borrowing that model, which I think is key. So that first paper that I talked about with Betty and I then wrote that in a book, and that was published by Templeton Press, is really how do we bring back that holistic part of care. We've always been very, very much interdisciplinary, and so our work has been very much focused on interprofessional collaboration. So the ISPEC course that I will talk about is for not just physicians, but it's for all clinicians in partnership with clergy. This is a very bad rendition. I did this myself from Google Images, but trying to just pictorially show what that model is like. So in inpatient settings, there are board certified chaplains. There are many others on the team, all of us addressing care. And then I put this in the middle to say, if a patient has a faith community that's important to them, Gary Gunderson has done a lot of, I was inspired by his research where he looked at the linkages between faith communities and hospital care and how faith communities actually can help post-hospital visit. So it might be a faith community, it might be a meditation teacher, it could be a spiritual director, whoever that is for people, a pastoral counselor. There's data now that in the United States, Wendy Cage did a study showing that people are becoming less religious, but more spiritual and looking for that expression, which I think to many of my colleagues who are faith community leaders, they say that's a challenge to us to try to see how we can meet those needs as well in our faith communities. And what we're proposing is the chaplain who's here in pink might be the person that then links with the faith community leaders. That's the kind of model, but we address that as generalists as well. So what is clinical spiritual care, which is what I've been really passionate about, attending to the human spirit suffering. So, assessment, diagnosis, and treatment, identification of spiritual support. I talked about this model, accompaniment. And this is what I'm going to focus part of my presentation today. This is what I would think of as encountering the sacred in clinical care. how do we accompany people? So if someone says to me, I don't feel God anymore in my life, I don't say, oh, well, why don't you talk to your pastor and try to go to church more often? That's not where that person is. They're suffering, right? So I need to hear them. That type of distress is not fixable, but with our accompaniment and our listening, people can find answers for themselves with our presence. And that's what we do as clinicians. And that's what board certified chaplains are trained at doing. So very, very, very critical piece in our interaction. Our training always should be the scope of practice. And I think that's why Dan Somasi, my good friend and colleague, writes that we really shouldn't get into this. It should be all in the area of the chaplains. Yes, chaplains and faith-based leaders have training in this, but that doesn't mean that we can't be present and listen to the story. So it's very, very important that we do that as clinicians. So clinicians at the bedside, we complete a screening or history depending on what our level is. So it might be screening if people are screening for other things. And then in the visit, I'll give you an example, offer presence, help patient identify their own inner resources, not tell them what those resources are, but help them identify that, asking questions, tell me more. What has worked for you? Tell me a little bit about your faith community and what that means to you. Include their spiritual beliefs and values, document that in a plan, always ensuring the dignity of patients. So respect and not making judgments, and refer to spiritual care professionals. Now, chaplain interventions would be confirming or changing that diagnosis, saying, Christina, I don't think it's quite bereavement. I think it's actually more complicated. And this is what I think it is. And this is what I've done. And in your follow-up visits, you might follow up in this way. They have spiritual interventions and they write up assessment and plan. So my colleague, Rick Bauer, I'm so lucky that he's working with us now. He is a Catholic priest. He's a Maryknoll, so he's been a missionary all his life. He also has a master's in social work, and he is a board certified chaplain. He's a wonderful person. So he's working with us at GWish. What really talks about, it was interesting to him when he first came on board as a chaplain at GW. They said, Frank in room 202 is talking about God. Can you go over there? So he says it's more than a referral to people that are talking about God or who are identified as religious. Everybody, chaplains work with everybody. And so trying to change that culture about understanding the richness. Chaplains work with patients of all beliefs, not necessarily religious. They can be atheist and agnostic or questioning. Chaplains work with them about their health issues and in the context of their health issues, but chaplains also support us. So part of their training is being with staff in clinical setting, and they are immense supporters and great resources for us. I just wanted to bring up a little bit about the demonstration project. So in our cycle 1, many are looking at spiritual assessment and integrating different tools into that chart. They're determining effectiveness of the screening and looking at the collaborative care. So our model again is, yes, we refer to chaplain, but it's a partnership, and we hope that they come back to us and tell us what we can continue as clinicians. Almost all of them are showing that spiritual distress is over 55% higher in some of the other sites. And this is amazing, they've secured funds from their hospital. Their clinical settings have been so impressed that they've actually said, okay, what you've done here in neuro-oncology, we want it also here and here and here. And they're smart. They're using this data to leverage hiring more chaplains. So really exciting to see that happen in this early stage. They've all been through our ISPEC course that I'll talk about. And so they do train their colleagues in that model. A lot of the quantitative and qualitative data is looking at outcomes of that collaborative model. They've, of course, done media and other presentations, and they're presenting at many. One presented recently in the National Association of Catholic Chaplains, APC, and others. And as I said, they're securing other funding, and there's many, many others things that are happening. I want to bring up this, and Harold, I believe you were part of this meeting, weren't you? Where we developed the type of inquiry. You were part of that meeting. So we looked at, spiritual screening. It's brief, open-ended. history. Now, I modified that. They all determined it was brief. Spiritual history can be brief, but more likely moderate. So that's really done in the context of an exam. Probably, we blotched it in the social history, or now called personal, where we ask about, do you have any significant relationships? What kind of work do you do? We talk about exercise and nutrition, and then smoking, alcohol, and drinking, and safety at home, and bring up, what matters most to you. Is spirituality important to you? And that's how we lead into it. For many visits, patients, especially in my palliative care clinic, they will bring up pain and bring up something else. They'll say there's pain, but there's more than physical pain. So I do address emotional, social, and spiritual pain often early on in that visit. So you contextualize it. But what I want to say here, and we don't have that in that chart, is beyond this type of inquiry. So screening, history, and spiritual assessment is the fuller one chaplains do. Beyond that is inviting the patient to share what matters most. And that's where I think presence comes into it. So Chaplain Kibben, who's the first woman chaplain of Congress, of the House of Representatives, she shared a story at a meeting where I was interviewing her. And she's a very accomplished woman. She was some level admiral, very high position in the Navy, and a board certified chaplain and an advocate for chaplains. And so many years ago, she was still in the field, and they were putting back, helping people who were wounded, kind of getting them ready to go back to the service, to the war. And of course, she found that, we all find that hard, but that's part of what's there. And so the young man didn't want to talk to her. She far outranked him. He was completely silent. And she didn't really know what to do. So she sat there. She sat with him. And then she said she's never really done this, but she pulled out a Bible from her pocket and read, I think it was Psalm 23, but she read a psalm to him, and she was reading it. And then when she looked up, there were tears streaming down his cheeks. And he says, that is the psalm my grandmother read to me every single night before I went to bed. So she says, how did that even happen? Right? The sacred in the room. And she says, our role as chaplains is to give light to that. And that is often what happens to me when I move into that presence, because I do feel that space is holy. I do feel the sacred. And when I move into that silent space, it's not me alone who's doing that. It's something greater than that. It's the patient, it's the encounter, it's love, it's compassion. For me, it happens to be God, but people describe that in different ways. And I think that is the most critical thing that we can do. So I wanted to talk about Michael with regard to that. So he was and all the details are changed, but he was my very first patient in the pandemic on Zoom. I was already freaked out about doing this on Zoom, thinking it would never work. And how could I be present to someone if they're suffering? Are they really going to be sharing that on Zoom? And he did, actually. He had a very difficult story, as you can read on that slide. He was 68. He was beginning to, he had a difficult divorce. He was beginning to realize that there was something not quite bright enough to compensate for that. And I'm not the same person I used to be. And, I then, sometimes I do goals of care, and I was moved to do that early here rather than to wait later in the visit. So I started a goals of care discussion. And he says, what will happen if I get COVID? As a typo there, I want to live. And then he pauses at me. He says, if I die, do you think God will think I was a good man? So we sat in silence. We sat in silence as he just was in that moment. And of course, after hearing his story, his wife had abandoned him. He raised all the kids by himself. Of course, I wanted to say, of course, God's going to think you would. But I didn't do that, because that wouldn't have helped him at that moment. That just to let him sit with that question and then talk more about what that means to him. That was a profound intervention, I will, not that I did, that was in the visit, allowing for that space to be present and not to say anything, but to show and express real interest, not this kind of thing of, oh, okay, sorry that you had a hard time, but really, really being present. That's what is so critical to clinical care. So in the FICA tool, which is a spiritual history tool I developed, he was raised Catholic. It was really interesting, his spirituality more personal now, perhaps, but he described it as a moral compass. And that actually became very enlightening as I treated him over the many years, still do. He is a rigid person and he has a clear sense of what's right and wrong. And that can be a little challenging with his kids who are not quite like that. So there's, and when I said that, the daughter said, wow, now I kind of get how he's been that way. It was really elucidating. She was in the room, in the Zoom room. Very important to him. He's worked with a spiritual director in the past. Community is his family. He feels isolated. And then the question that he had asked earlier. And then it's just about writing up the whole person assessment and treatment plan. And we should do this. We should, in all of our notes, be thinking about each of these domains and be writing up about that. I did refer him to a chaplain. He eventually, but that was active part of COVID, he eventually did get into a beautiful assisted living. And that chaplain did visits out there with him. And it helped him a lot. The chaplain was actually a former Catholic priest. So he had some connections in the diocese in Arlington. So he was, again, this patient was extremely bright. He really was passionate about the environment. So he was able to do some lectures for the diocese on this. And and the chaplain always reminded me that as I saw him getting physically worse, the chaplain would remind me how well he was spiritually. And it also reframed the way I would interact with my patients. So very, very powerful interaction in that. Now, we did frame spiritual health and distress. That's something I did early on because I got so much pushback from physicians, as I'm sure Harold did too. This is nothing in our realm. We should have nothing to do with this. So really the diagnostic part, I think, made a difference. That at least we need to identify that. And palliative care and family medicine, that's done. So compassionate presence, I've talked about this a lot, but this is that sense of, I think, the recognizing the suffering, and it means to suffer with. But to me, it's really being able to understand that there is something, or feel that there's something beyond physical pain or emotional or social. There's something that I pick up. Intuition is actually very important in clinical care. And we can all talk about where we think that intuition comes from. I think it's a sort of a connection with the divine, perhaps, or sacred. But however we understand intuition, it's the something else is here and with this person, and how do I open up to that? And it is often that deep suffering. And I love this. I love this quote here from, again, Father Rick. His mentor was a physician, and MMM is also a Maryknoll and a missionary. And what she says is, our role is to stand in the face of massive suffering and not run away. And how many times have we witnessed that in our clinical setting? Perhaps it's not the massive suffering of working in a war-torn country, but there's massive suffering that people experience in their lives: loss of a job, loss of a spouse or a loved one, just not knowing what to do. And especially in the face of the pandemic, there's been much of that. So the way that I've thought of this, and it's been written about in different ways, again, this happens to be a picture from that beautiful sailing wildlife area, is that with spiritual distress, people often speak in terms of being fragmented. They may not know that word. They may just say something's not right. We need to listen to that theme. But healing and wholeness can occur. And I strongly believe it's our accompaniment in that, and referring to the appropriate resources. For some people, that comes from God or a higher power. From other people, it comes within the context of relationships. But there is a possibility of healing, but it's not via a medication. Of course, I do want to say that one of the things we do is to try to distinguish spiritual distress from depression. That always has to be the case that you may be aligned, but oftentimes spiritual distress is ignored. I have permission from this patient, a wonderful person that I cared for, and he died during the pandemic. But this is a beautiful picture with his wife, pancreatic cancer. He lived actually a long time for an advanced cancer. But he said there's nothing like a diagnosis of terminal cancer to sharpen the focus on survival. Yes, but beyond that, on the wondrous experience of living. So he was a remarkable person who could talk about the suffering, but also move beyond that and incorporate it into his life. And he did that a lot on his own, I would say. Parker Palmer has talked about witnessing the sacred. We don't want to be fixed. No one wants to be fixed, but people want to be heard. And so if we cut them off with, you're going to be fine, or if you do this meditation, they'll take care of it. That's not listening to the deep pain that's inside. So these, coming out of our ISPEC course are the recommendations of how we practice that. And what that calls us to is being aware of our own spirituality. We cannot be present to another's suffering if we haven't addressed that in ourselves. And what are our resources that we use to be able to stand in the face of that suffering and not get broken down and torn apart? And that's really, really key. So Dr. Jim Blatt and I developed a program called Reflection Rounds. I'm not going to go into great depth due to time, but just to raise your awareness to this, that it is a form based on a form of spiritual direction, but it's broader than that. But it's really, how do we become aware of our call? And that's what guides us. How can we practice contemplative listening? Those are some of the objectives in that. And then often, and Rachel Merriman says this, isn't after all our medicine or our clinical or other practice a spiritual practice? How can we reframe that and say that we too are spiritual beings, and we bring that into our practice? So we have part of making healthcare whole, part of the realm of that is that we need to be aware of our spiritual dimensions in our life and then be supported in that. So reflection rounds are, it's more of a contemplative process. We tested this in 18 medical schools, again, a Templeton funded practice. And now we're doing in our third year clerkship, ironically with the surgery rotation, since the director of that has experienced this and has been wanting to do it. So what do the students do? They share a story of a recent encounter with a patient. How were they affected spiritually, humanistically? Did they learn anything? What was the meaning of that encounter? And we listen without interrupting. And it is one of the things that the students come out and say, wow, I was heard. No one tried to change me. But more importantly, there are tears in the room. And it's so moving because they say, I don't want to be like I see the rush doctors running from one room into the other. I want to be there. They use the word presence. I don't bring that up. I want to be present. That's my call. That's my vocation. Powerful program. So this is a little bit of what we teach for the facilitators. There is a training for facilitators of how to, use that contemplative facilitation. And it's really, in our own practice, it's resisting the urge to fix things. Doctors are great fixers, but we need to learn that sometimes we move out of that listening, not doing, and then following the patient's lead in that, not ours. So instead of what's your pain on a scale of 1 to 10, we let the patient tell us about their suffering. Hard for doctors to understand. So I want to close now with the ISPEC course, Interprofessional Spiritual Care, which is something that we've been working on. We've had many, many courses now, and I'll tell you a little bit about that. The development of that really started in 1999 with the Association of American Medical Colleges, where we developed competencies or learning objectives and outcome goals for spirituality and health education. Brownie Anderson was very instrumental in that. She invited deans, and we had a consensus conference, again, developed a very broad definition of spirituality as meaning, purpose, and connectedness, and a search for the transcendent, however people understand that. And then we ran a curricular program for Templeton in spirituality and health. 2009, I talked about that conference, again, broad definition of spirituality. In 2014, we did a national conference around competencies in spirituality and health education. That's where compassionate presence became its own competency. In 2012, we did an international conference based on '09, as I mentioned. 2014, we piloted ISPEC at the Veterans Hospital here in DC. It was modeled after LNEC, and then fantastic news. Going back to '99, Brownie Anderson, I noticed later than that, I noticed that in the exam that all of us have to take to recertify as in any of our specialties, there were no questions at all on spirituality. Harold, I'm sure you probably noticed that too. There were few ethics eventually. Dan Slamacy got those in, but nothing on spirituality. Palliative care eventually has questions about FICA, but nothing formal. So Brownie Anderson at the AMC said, one day you're going to have to get AMA to pass a resolution, and then that will give you the opportunity to then approach LCME and others, which we're doing. So in June of this year, AMA passed a resolution in spirituality and health education. And I will show you what that says, but that is an amazing achievement, not just mine. Believe me, this was done with a group of colleagues who introduced me to people at the AMA. It was definitely collaborative, and many people to thank for this. So the pilot that we did, as you can see here, these are some of the things that we wanted to teach, spiritual history, et cetera. And there was definitely progress in that. And so based on that, we developed ISPEC. And if there's an online version for clinicians, and chaplains can look at that as well to see what we teach clinician. But the Train the Trainer program is one in which we invite clinicians and chaplains to attend the course to learn how to teach this when they go back to their settings. And we've had phenomenal attendance because a lot of it is virtually. We've been able to have people from around the world who are doing this and are very engaged. These are our overall objectives, guidelines, basics of implementation, define spiritual distress in adults and children, recognize skills for practicing compassionate presence, identify communication strategies, the FICA or however some of the other strategies, develop that whole person assessment and plan, and then recognize our own spirituality as an integral part of professional development. And I think this is where the problem is right now. In the corporatization of healthcare, we're kind of detached from that. We're forgetting about our call. We're focusing on epic and documentation. I know that there's a need for that. I'm not criticizing that, but we need to come back. Many examples of goals this has been published on, but in spiritual care models, assessment, et cetera. And then people doing some wonderful things with grand rounds, professional development, a lot of reflective debriefing, successes in implementation, collaborative interprofessional discussion groups, training, resources, conducting research, pilot funding people are getting, self-care. So a lot of accomplishments, some challenges too, because we don't have enough chaplains in a lot of clinical settings, but that is changing bit by bit. And then one of my students found it incredibly inspiring. He felt chills and familiarity when he came into our medical school with this course. He felt that there was this excessive focus on the technical and not enough focus on the sacred aspects of medicine. And again, bringing the sacred into care. And he decided to do a pause moment before seeing patients so that he could center himself and become prepared for the sacredness of the encounter to come out of students' mouths. That is really the core of integrating the sacred into healthcare. A big community has started. We also, part of the ISPEC Train the Trainer is to meet every other month for a year to help people implement goals. And so every time we've been coming to the end of the year, people say, can we keep going? So we're trying to figure out how to do this, but there is an ISPEC community, and we're going to try to have at least once or twice a year, just an online meeting so people can connect with what they're doing. Here's the resolution. So there's two big points. Addressing patient spirituality in medicine, medical education, and practice. Our AMA recognizes the importance of individual patient spirituality and its impact on health and encourages patient access to spiritual care services. that, again, the broad definition is what it's not just about religion. It's this broader definition that also, though, encompasses religion or other types of belief was really important in this work. And then they encourage the availability of education about spiritual health defined as meaning, purpose, and connectedness in curricula and meaning, medical school, graduate medical education, continuing education as an integral part of whole person care. And basically, they've used many of the ISPEC overall learning objectives. So this I'm very excited about and hope that we can do more work collaboratively around this. Our ISPEC program, we are going to do an in-person one at GW. Would love for you to come. It's October 28th and 29th. Learn how to teach others. Ideally, we would love chaplains and clinicians to come together. We've made exceptions, of course, due to workforce issues, but it's a great way, and it is a education course, but we have small group reflections and ways to implement things. So it really is a different kind of a course. We do and have been holding a retreat in Assisi, Italy during the pandemic. It's been virtual. We will be doing our next one October 2nd to 8th in 2025. The environmental changes have made people not want to come to the summer in Italy. So we're doing it. That happens to be the Feast of St. Francis, which in Italy is very festive, and it's a place of interfaith dialogues. Everybody comes to Assisi. So just to let you know about that, you can see that on our website. And I just want to close that together. We can help reintegrate hope and healing into our health system. So thank you so much for your attention.
Christina, my gosh, what a presentation. Passionate, articulate, and informative. Thank you so much. So we have a little bit of time here for people in the who here to ask some questions to Christina. I'm sure there'll be quite a number of questions. So feel free to just unmute yourself and ask your question. There are a few in the chat that, let's see, Paul asked, could we get a link on the AMA doc that implemented spirituality into the recertification process?
Well, it's not recertification exactly. That's not it. It's their recommendation. And from that, we can then go to another level about requiring curriculum in a stronger way. But I can send you, we have a document. AMA is going to put something out that says they're putting out little messages of this is a resolution. Like, for example, the senior physician section passed a resolution on ageism. So they posted that. I think we're going to be next in line. And as soon as that happens, I'm very, very, very happy to share that with you.
Wonderful. I think Linda has a question. Linda, go ahead and unmute yourself and ask your question.
Thank you for listening to me. This was a wonderful presentation. And I'm wondering if you include faith community nurses in any of your work.
Yes. Thank you for saying that. Thank you for saying that. Actually, when I first started this way back when, on that timeline, we worked a lot with faith community nurses. And there have been faith community nurses that come and partner. And I will tell you, on occasion, they've not been able to find a chaplain, but we still come because I know that they have additional training in this. So absolutely, if you are a faith community nurse, I would love if you could share that information about ISPEC. I have some networks, but I don't have all the best. So I would really appreciate that so I could target it even better. Right now, I'm just doing it with people I know, and they're sharing it for me, but I would love that if you could.
Yes, I will. I actually heard about this program through one of our Lutheran faith community nurses in the Washington area.
Right. So you could actually email me. I'm going to put my email in the chat, and you could email me, and I would really appreciate that. And then we have, it's going to be in person. So at least, locally, I know that there's many people in the DC area, but again, people from around the country are totally welcome to that.
Great. Meba is next. Meba Kanda, unmute yourself. Go ahead.
Thank you. Thank you very much. And very, very grateful to be here. Beautiful presentation. I'm from South Africa. My question it's a comment at the same time, is that yes, spirituality has to be definitely brought into healthcare, and we do that through education. But what's the place of spirituality in leadership? Leadership, I believe, is very important in healthcare. So, what could be? How could we introduce that in leadership? And possibly, in doing so, it would help to bring spirituality in healthcare. Thank you.
Yes, I think it is critically important. And that's something that we focus on in the mentoring in this train the trainer. So the idea is that the people that come to our course are trained to be leaders in this area back at their healthcare settings. Marvin Delgado, who is a physician, a palliative care physician, one of our faculty, a good friend and a collaborator with me, also does quite a bit of training on spiritual leadership. So I think it's really critically important because that's how change can occur. And we're finding that with the demonstration projects, our goal with those teams is that they become future leaders in this area, and they are clearly functioning as spiritual leaders within their within their communities. And since they're a clinician chaplain pair, I think we're seeing leadership in both of those areas. So important that chaplains also are seen and trained to be in leadership positions of that nature. And I was in South Africa a number of times, so I think it's a beautiful place. And there's a lot of good work going on in palliative care in this area. And I'm not sure how much they've integrated, but we have had a participant or two from South Africa attend some of our online courses. Yeah.
Wonderful. David, you're up next. David Music.
Hi, Christina. It's great to see you again.
Nice to see you again. Wow, it's been a while.
It is. Thank you for an awesome presentation. Really enjoyed it. Working with an interdisciplinary group here in Roanoke at our health system on the concept of trauma-informed leadership. Are you aware of any bridging between spirituality and trauma-informed care in general, trauma-informed leadership, that sort of thing? And we're also looking at things like adverse childhood experiences and how that might impact leadership.
Yeah. I would recommend, do you all know about transforming chaplaincy? So George Fischette was a chaplain who also had a PhD and was a researcher. He's one of the first to train chaplains to become researchers as well. So I was an advisor for his Templeton-funded project called Transforming Chaplaincy. He stepped down, and one of my good colleagues, Shaba, has taken leadership in that, and he's a research chaplain as well. So I believe that they are working on that. And so, yeah, so Transforming Chaplaincy is the organization. And again, I can, if you email me, I'm happy to send Shaba's email to you. And I believe they are, I'm hearing, I'm not familiar with it, but I've heard of many people looking at trauma
Awesome.
informed care. Yeah. And one other thing I'm hearing with chaplaincy training is that they're going to have like a very basic mental health course as part of clinical pastoral education because of some of the, not, trauma being one of them, but the mental health issues and what is, that they at least recognize that as they're not specialists in mental health issues, but that they may touch upon it in the course of talking with patients. So to be trained to know how to deal with that and who to work with. Yeah.
Awesome. Thank you so much.
Brent, I think you're next.
Hi, I'm sorry, I have no way of putting my little hand up through the technology, but Dr. Puchalski, thank you so much. This was wonderful. I was at ISPEC in Hawaii a few years ago.
I recognize your name.
Table 5, if you remember. Yay. And yes, we at that time were trying to build a department, and we did. I don't know if you remember the manager of the department, Sean.
Sean, yeah.
Yeah. So, and we brought in more chaplains. There were 4 of us. But then part of it's due to COVID, I think, but there were budget cuts. Sean's job was eliminated. All the other chaplains were eliminated. The palliative care department was completely reorganized. So now I'm the only chaplain.
Oh my gosh.
And so I really, what you were saying in the presentation about the importance of the medical team perceiving spirituality as an issue. I think is a big issue here. We're having a hard time. I think it's not true of all the medical team, but I think administratively it's not on the radar. So should we send another group to another ISPEC training?
Yes, but even more, yes, but we have now with our online, we have about 10 or 12 people from the different islands that have somehow connected. So there is a very robust ISPEC community. So yes, please send more. That would be fantastic. And I'll connect you with the others as well. They're doing different types of projects. And I don't remember all the different islands. I know the mainland has a number.
Well, so, I am not in Hawaii. I just went to the ISPEC in Hawaii. I'm in Reno, Nevada. So
you're in Reno. Yeah, absolutely. Yeah. Oh, I see. You went to Hawaii, but you weren't there. Yes, definitely come.
Yeah, thank you. Sure. I appreciate that.
I just want to make sure that some of these questions that we've addressed it. Currently working to become a chaplain focused in clinical work updates. So I think our updates for that course, but again, transforming chaplaincy would be a great place to get updates. And I think I addressed everybody's questions in here. Yeah.
I think John has a question. John?
Hi, Harold and Christina. Our paths crossed many years ago at ICAHS. It's great to see both of you again. I had a question related to the social determinants of health. I know if anyone's familiar with the Healthy People 2030 initiative through HHS, they said they currently have, I think it's 5 social determinants of health. Has there been any work to get HHS to recognize spirituality as a social determinant of health? That would really, I think, go far.
Yes.
And having the government include something about addressing this when they do their when they release the new Healthy People objectives every decade.
So that was the goal of that paper, the public health paper that I referenced, that Howard Koh, who was former Assistant Secretary of Health under Obama, he's very involved with that. And that's kind of the goal, the policy goal. They're doing the homework, getting the paper out, the guidelines, and then moving to this next area. And happy to, keep you in the loop on that. Yeah.
Awesome.
That's our hope. There are other initiatives too that are, so Interfaith America is doing a lot of work around, like, as I said, bringing faith-based, working more on faith-based clergy, getting back more involved in healthcare. And some of Gary Gunderson was part of that same group. That's on that paper, as well as 1 or 2 other papers. I'm happy to share that paper. If you email me, I can share that publication with you too.
I'll do that. Thank you.
Okay, we have about 2 minutes, maybe time for one more question. Does anyone have a burning question that they can ask Christina? Meba, it looks like you're unmuted.
Yeah, I just wanted to find out, is it possible to have Christina email?
Yes, I put it in the chat. Did you see that?
Thank you. I'm struggling to find it. I did not. Thank you.
It's an abbreviation of my name, but I'll put it again. It's CPUCHALS@GWU.edu. I just put it in again.
Great.
It's been such an honor to be able to spend this time with you and with my friend Harold. And thank you so much for your great attention. And the questions were really, really good. And hopefully I'll see you at ISPEC or one of our other projects. So
thank you. Thank you, Christina. Again, what a wonderful presentation. And I'm sure many people will be contacting you. And thank you, everyone, for your questions and for your participation. And be with us again next month.
Take care.
Bye, everyone.
Bye.